Yes.
Recording in progress.
Can you hear? Good morning. Honorary IOA President Dr. Shiv Shankar, I welcome you for this first session of IOA POSI academic session. I request him to have inaugural address to start our meeting. Thank you, sir.
Thank you very much, Dr. Ajay Shinde, Chairman of the Pediatric Subcommittee of IOA, for having started this webinar. And I would like to congratulate the IOA Subcommittee with Dr. Shinde as the Chairman, Dr. Kamlesh Devmurari and Dr. Thanappan as the members, along with a good support from the President and Secretary of POSI, that is Dr. Dhiren Ganjwala and Dr. Sandeep Patwardhan. We have a strong team of pediatric orthopedic surgeons in the form of Dr. Kamlesh Devmurari, Dr. Sandeep Patwardhan, Dr. Dhiren Ganjwala, Dr. Govardhan Ingale, Dr. Rajeev Negandhi, Dr. Kirti Ramnani, Dr. Maulin Shah and Dr. Atul Bhaskar at present to share their vast knowledge with we all people. Friends, this year, as President of IOA, I have tried to include the subcommittee specialty people also in the group so that it's a symbiotic relation. IOA is benefited by the President and Secretary of the Pediatric Orthopedic Society with their vast knowledge and experience, and similarly, the IOA members will get benefit of their presence in our meeting, and the meeting will have a better, fruitful outcome if the subcommittee associations are also formed. With this intention, we have formed this symbiotic relation. I hope this goes strongly and this will be benefit to all. This meeting of pediatric orthopedic group will be on last Sunday of every month. We have planned from 11 to 1 p.m. Thank you very much for having me here today. I declare this scientific session open for deliberation. Over to you, Dr. Shinde.
Thank you, sir. Clubfoot is one of the common congenital deformity usually seen by orthopedic surgeons in their day-to-day OPDs. The incidence is 1 per 1,000 births with male predominance ratio 2:1. Almost 40% are bilateral. There are two varieties, flexible and rigid. Ponseti technique has revolutionized the management of fresh cases and is first choice of treatment. One must be aware of idiopathic CTV and other varieties before starting the management. It is essential to know the sequence of correction of deformities, cavus first, then adduction, and lastly equinus by percut TA release. Otherwise, breaking of foot vertical talus can occur. Most challenging job is to maintain the achieved correction, for which abduction orthosis has to be used for a long time. There is a risk of relapse in almost 40%, out of which 30% are because of lack of compliance and 10% due to atypical clubfoot. Recurrence is more likely in under-corrected foot. Forefoot adduction is a common recurrence thing, which again can be managed with serial casting, splinting in initial phases. If not responding, then surgical management be required. In spite of all, many times we may see neglected or relapsed cases in various age groups. which is having a tremendous impact on child's social, educational, and even psychological environment. We must update our knowledge regarding advanced treatment as well as developing awareness in parents about orthosis, which is necessary to produce a wonderful result. There is vast difference of CTV presentation in Western world and Indian scenario. Incidence of neglected recurrent resistant cases are negligible in Western world, while it is quite high in our scenario, where the presenting complex CTV deformity is a combination of deformities at foot, midfoot, hindfoot in all planes, involving both soft tissues as well as bones and joints. This is a really challenging job of our orthopedic surgeons. In such a situation, we have to follow IOA presidential theme, Atmanirbhar Orthopedics, Indian at heart and global in competence, by making our orthopods enriched in knowledge to tackle such a cases and to achieve goal of plantigrade, supple, functional, painless foot. To make young India healthy and free from disability, this is the motto of today's webinar. Now, I would like to share a case of a 14-year male school-going, neglected, severely deformed bilateral CTV. This is how he presented to me in October 2008. Severe deformities. This is his clinical photographs and X-ray. Do you expect such patients are there in Western world? How will you manage this patient? Obvious answer is yes. I manage this case with JES. The JES system addresses the problem in such a manner which correct all the components of the deformity and simultaneously allow lengthening of all contracted tissues without scarring by distraction osteogenesis. This is his final clinical photograph with and without shoes. This is his gait with shoes and without shoes. Regarding management of neglected clubfoot, I am having two publications in Index Journal. With this introduction and opening remarks regarding Indian scenario, I am going to hand over mic to today's convener, eminent pediatric orthopedic surgeon from Pune, Dr. Sandeep Patwardhan, who is also Secretary of POSI and advisor to IOA 21 Pediatric Orthopedic Committee for further proceeding. Thank you very much. Jai Hind.
Thank you, sir. Without much ado, I hand over to my president, Dr. Dhiren Bhai Ganjwala, who will conduct today's webinar.
Yes, thank you, Sandeep. Thank you, Dr. Sinde and Dr. Shiv Shankar. It's really a nice initiative to have so much important topic, because Dr. Sinde has rightly pointed out that the incidence of clubfoot is 1 in 1,000. And it occurs everywhere. Every nook and corner of India, we face this problem. And not every child is fortunate to reach to the care of pediatric orthopedic surgeon. So it's very important that general orthopedic surgeon should also be able to treat this deformity with confidence and with great skill. There is a lot of advancement in the knowledge in this area, particularly Ponseti treatment has become a gold standard. But we face a lot of challenges with Ponseti technique, and in India we have a lot of cases which are presenting late. So we have designed a program specifically considering the general orthopedic surgeon who are treating this condition and what are the challenges which they face. And keeping that in mind, we have designed this program. So with that, I invite the first speaker for the today's program, and that is Dr. Govardhan Ingale, and he's going to speak on a topic which is very important, because now with the very good antenatal ultrasound screening, we see a lot of families coming to us with an ultrasound report where they have, the ultrasoundologist has suggested that this child has a clubfoot, and family passes through a really stressful period. So how to answer the queries, how to satisfy the family that this is not really a serious problem. I request Govardhan Ingale to share his views about this important point. Over to you, Govardhan. Thank you.
Thank you, sir. Thank you very much. So with this, I will start my talk. As sir has rightly pointed out, the problem with once the patient comes, the parents gets the report from the sonologist in their during their routine ANC checkup that child has a clubfoot. So the diagnosis is very easy, and any orthopedic surgeon can definitely plan for treatment immediately once he sees this. But what's the difference between this diagnosis and this clinical diagnosis? So one is on the left side is after birth, so you are treating the patient, but on the right side it's the parents whom you are counseling, or indirectly you are treating them and you are making them comfortable and acceptable with the deformity. Because once this report comes in the hand, there are lots of queries in the mind of the parents, and obviously the hitachintak or the friends and relatives are around, and they keep on giving so many ideas to the patient, so many nooks to the patient, that do this, do that, don't do this, or maybe may have to abort. And every right here and there, at every corner of their life, there are people who are suggesting some or the other treatment, and ultimately the family lands up in this. So if you see this picture, there is a small baby which everyone is examining on their own end, so they have their own ideas and own thought process. So what exactly we should do, or what exactly, once the patient is referred to us, the parents are referred to us with the deformity or with the problem that the child has a clubfoot. So parents have in the mind that why me, like why I'm involved. Is it really some curse, or it's some problem in the family? Or it's what would be the reason, like why the baby has all these problems? So we have to sort out all this by doing a counseling to them. So what I feel the best thing is to first them understand the problem. What is the problem? What the child has the problem, and that's how we should start the treatment, so that it's little bit easy to them to understand, become comfortable as the pregnancies go ahead. So as Shinde sir has pointed out, it's a commonest problem, and it's 1 in 1,000 live births, and commonest in males, obviously. So we have to tell them the causes of this, like, because this is going to decide the treatment protocol once the child is born. Okay, so if it is an idiopathic or the primary clubfoot, then obviously it's a non-syndromic, so there is no specific cause, and it's most commonest, more than 90 or almost up to 90% that there are idiopathic clubfoot what we get. The neuromuscular or the secondary or syndromic clubfoot are obviously less common, less than up to 10%, and obviously treatment is going to be a little bit tedious for them, and the causes are different, like neural tube defects, spina bifida, or some congenital anomaly associated with trisomy 2018 and something like that. So if the child has that, then we have to go ahead and take the history in detail and know if the child parents or someone in the family has the clubfoot issue, in a sibling has an issue, or there is some syndromic issues in the family, or is it a consensus marriage or something like that. So we have to first plan on the history part of it. Then obviously maternal smoking has another risk factor, or oligohydramnion also has a factors, and it is commonly associated with many problems. So we have to explain, if possible we have to keep few pictures of the patients or the PPTs ready with us to show them like how it really progresses. So treatment depends upon the which type it is. Is it an idiopathic variety, or is it a secondary or syndromic variety? If it is idiopathic variety, obviously most of them does respond to conservative treatment. They have really a very good outcome. That's what we have to explain to the patient, that they have a very good outcome if we treat it in time and if we treat it properly. Then obviously neuromuscular or the secondary clubfoot has issues and it may need surgery, It may need a prolonged treatment, but obviously the functional outcome can be comparable. It can be nice if we treat them in time, and if we really, the parents are keen, and we have to make them aware that they have to be ready with the treatment, and it can be a treatable condition. It's not something like that we can't treat it only. Okay, so the query in the mind of the parents come that does it need an abortion? So as I told you, in many cases we have good outcomes, so abortion is not required. So we have to do, the next thing is reassurance to the patient that everything is okay, don't worry about it. If the child has some other issues, then he may need some other investigations that I will come further in my talk. So if abortion is needed, there are some what is legal aspect of now medical termination of pregnancy, that is MTP in today's Indian law. So the MTP bill amendment has been done recently in 2020, and which has changed. I just miss out of the context. I have brought out this point that now initially after 20 weeks the MTB was not allowed, but now it is allowed it from 20 to 24 weeks with the consent of with the proper medical board, and obviously after 24 also, if it is really a fetal abnormality, then it can be done. So these are few changes in MTB amendment done by the government of India. So the next question can be, what deformities can be associated with clubfoot? So commonest deformities can be torticollis, developmental dysplasia of hip, and sometimes the spinal defects. But the torticollis and developmental dysplasia has really very good outcome with the treatment, and spinal defects too. So what can be the problem if the child is not treated? Then obviously the problem can be difficulty in walking, deformity, callosities, and mainly the social stigma. This we have to explain so that they should be ready for the treatment as early as possible. So the next thing, like, they will point at us and ask us like how we are going to help them. So we can definitely help them by correction of this 5 deformities, that is cavus, adduction, varus, equinus, and tibial torsion. And how we do correct it is, this gentleman Ignacio Ponseti has developed a very good corrective casting method. And according to him, for idiopathic clubfoot, the primary clubfoot, it can be successfully treated non-operatively. So he had just shifted the whole paradigm of the treatment from changing the lever of the correction from calcaneonavicular joint up to the lateral head of talus. So this is like corrections, sequential corrections. Our next speaker is going to talk about this plan of this way of treatment, in which serial casting and small surgery will definitely, the tenotomy and then the bracing does help and correct the deformity completely. So sometimes we have a different reports from two sonologists. Some one says it is not there, the parent gets anxious, goes to another one, and the other says that it is not there. So that can be sometimes a problem. So what we should do, that if we possible, we should repeat the sonography, and if possible, we should advise an anomaly scan. So what is an anomaly scan, and what is the time for do that scan? So it's a 20-week scan. It is also called as, or the detailed scan of the child, and should be done with a higher, more sophisticated sonography machine. And it should be done within 21 to 24 weeks of gestation. And clubfoot routinely starts developing in second trimester of pregnancy, and it appears on USG actually at 16th week of gestation. But routinely, if anomaly scan is done, that is 21 and 24th week between, and that is the best time. So during USG, there are two types, 2D sonology is there, in which we examine the leg in the same plane, but the 3D sonographies are better because it is more morphological assessment, in vivo assessment, and multiplanar investigations can be done. So along with, if patient has a clubfoot, we should advise them to go for this kind of an anomaly scan, so that there is more detailed examination of the deformity, as well as they will assess the spine, the legs, the upper limbs, and the neural defect, any neural defect or any other anomaly in the child. So this is an antenatal USG which is done. Just a small clip. Yeah, it's like how it's seen on the USG scan, then the leg length of the femur, the length of the tibia and the fibula is also seen at the same time. And this is just a part of that whole examination. Then they do all the spine examination and the skull and everything, to know any other issues there. So this is now something new. This is a 4D scanning system. This is one YouTube video I have picked up. Play. So the difference between the 3D scanning is the static 3D images in a single plane, but the 4D has a multi-planar view and it's a dynamic examination mode. That's what they say, and it really helps to do this antenatal scanning, and this most of the defects are seen into this, and this screening helps because it has a very high sensitivity, 71%, positive predictive value is 81%, and negative predictive value is very high, that's 99.5%. So it really helps, and the diagnosis is very clean and clear, and we can definitely advise the parents accordingly what they should be doing once the child is born. And if it is diagnosed prenatally, and if we do this scanning and we are sure that there are no other anomalies, no other problems, and if we really start the treatment early, then we can go ahead and do the prenatal counseling. And after counseling, the few papers says that after counseling, the treatment immediately after birth starts, and that has been shown that if the diagnosis is made after the child is born, the treatment may be start bit later, maybe up to 1 month later. So that may have a problem in outcome of the total results. So the false negative rate can be seen in 10 to 30%, and false positive is quite high. That is because of postural clubfoots or positional clubfoot. So it's like that, then the sonologist should wait and should repeat the USG after 30 minutes to confirm it. So any other investigations are required? No, because the alternative imaging is not required after USG diagnosis, and the literature and genetic database has already very well proven that amniocentesis or karyotyping like examinations are not needed for this kind of problem. So having a USG diagnosis is sufficient for us, and we can go. Then the next question comes is a guarantee. What's the guarantee of the treatment? And obviously, everybody wants 100% assurity after once we start the treatment. But that's what we have to explain to them, that this is the man or this is the Ponseti, his own article in which he has 71% good results. Okay, that is in his immediate paper in 1963, and his paper, which was done after 30 years follow-up paper was done, and in which 78% excellent or good outcome has been seen, the functional outcome. So it's like that. So we have to tell them that if they want a guarantee, the 100% guarantee is there, but that is of my efforts. That's what I have heard once. Dr. K. Sancheti, the senior orthopedic surgeon in Pune, he was telling one of his patients that if they ask guarantee, what we should say. So we should say that yes, 100% guarantee of my efforts, and the rest is the time will decide. And then, as now Kirti will be speaking on for this gold standard, most of the papers has shown us this. So we have to explain to the patient that is the right treatment what we will be doing in idiopathic clubfoot. Now there is again a last question comes. That is always a googly for us. So can anyone guess what it could be? Anyone? Okay, I'll go ahead. So that googly is always a cost. They want to know about the cost, and I think our faculty will, with time, can explain us what should be the cost of the treatment, but it varies from place to place, person to person. So we are not sure, but we should try to do it with the minimal cost because we want most of the kids to get benefited. So what I shall do at the end, that I should improve the understanding of the patient about the problem. I should decrease their anxiety and reassure them that this is a treatable condition. Don't rush and do some other plan for abortion or anything like that. If it is not associated with any other problem, and to diagnose the other issues, we should do an anomaly scan if required, and we should promote the early treatment during parent counseling. Thank you very much. Thank you.
Yeah,
Govardhan,
thank you.
unshare your screen, please.
Oh, sorry.
While he is doing that, I'll just make one comment. I'll just make one comment here that antenatal, it is very important to look at the spine and the brain. A clubfoot which is associated with open neural tube defects or brain defects are the ones which may require termination. So you should counsel accordingly. Second, it has been shown now that there is a genetic problem and it's a developmental issue. The clubfoot may not be visible at the 14-week scan or the 20-week scan and can happen later. So there may be a disparity between the scan which says not a clubfoot and at birth you have a clubfoot. That has been shown because of the evolutionary genes and the way the contracting fibrosis happens. So you should be aware that you try to defend your radiology colleagues also, saying that sometimes it is not seen and it's a developmental thing and you may still have a clubfoot and which you need to treat. Dhiren bhai, over to you.
Yes.
You're mute, sir.
Yeah, thank you very much, Sandeep, for an excellent comment and very practical comment. And another experience I had only yesterday, the parents, they came with a child who was treated for a clubfoot, and they said that the ultrasonography was done, but the sonologist did not tell us about the clubfoot. So at that point, what Sandeep said is very right, that we need to say that this could be a developmental thing and it might have appeared after the sonology was or the sonography was done. So with that, thank you, Govardhan, for an excellent presentation. And now we go to the most important topic, how to carry out a Ponseti treatment. And no doubt Ponseti treatment has become a gold standard, but still we have to learn the minute details of that. And I'm sure that Dr. Kamlesh Devmurari, with his vast experience, is going to tell us about the practical tips about Ponseti technique. Over to you, Kamlesh.
Good morning, sir, and thank you, Ganjwala sir, for kind words. And so we all know about Ponseti method, and we'll refine some principles. So, according to my knowledge, and when I read the book of Fundamental of Ponseti, these 4 words, it's very interesting. So, how we will manipulate and how we will change the position of the bone, and how we will take the advantage of biological response of young connective tissue and bone. And for that, how we will apply cast. So there are 4 points we will try to understand in this topic. So before understand the Ponseti principles, first we will try what is the functional anatomy of subtalar movement. So that is very interesting video. When I saw this this video, the complete concept of clubfoot in my mind, it's completely changed. You will see that when we abduct the forefoot, the calcaneus is inward and it's extend. So when we adduct the forefoot, the calcaneus get inward and flex. So what by this maneuver, the Ponseti has changed all the concept of clubfoot. We will see that it's very interesting. When we abduct the forefoot, the calcaneus is inward and extend. When you adduct, the calcaneus get inward. So what Ponseti did in this? So before the Ponseti principle came, what in the kites method, what happened? Suppose this is a plane. You can see in the plane, the calcaneus is inverted and it is adducted. But we'll try to abduct and inward. It is very difficult. But we'll try to abduct the forefoot and all complex the movement, and simultaneously that heel calcaneus get inverted and varus get improved. That's very interesting phenomena. And the second thing we want to learn, according to the we'll change the position where we abduct the forefoot, how biological response, what is the exact mechanism occur at the posteromedial structure. So in the clubfoot, what is there? So in the whole posteromedial structure, that is so tight, like tendon, capsule, ligaments, all are tight. So what we'll do, what Ponseti did in his first maneuver, he just stretch over the posterior medial aspect and apply cast. So how cast will work? It will hold the position and maintain the tarsal alignment. Further, subsequently, they did a second cast at the time. He act as a fulcrum over the talar head. So what happened over the posteromedial structure? It again, the loose of the the retracting fibrosis, they lose the tensile strength, they allow further stretch. So you can manipulate more and it will be very easy to correct. So at the end, what he found that once we go gradual correction, simultaneously the whole tissue get lengthened and simultaneously there is a tarsal alignment, and also he found that there is a reshaping of talar head and tarsal bone and intertarsal surfaces. So these are the principle how he these are the two things, proper positioning and what is the biological response. So how we will use that practically? We all know that how it works. So this is a sequential thing, cavus, adduction, varus and equinus. It's a mixture of 4 deformity. So how we will correct? The first plaster should be cavus correction. I will show in later demonstration how we will correct. Then couple of 2 or 3 to 4 plaster for your adduction and varus. So in kite, they change the cast or they change the deformity individually. But here, Ponseti, what? There's a sequential corrections. Once we correct the cavus and simultaneously abduct the supinated foot, the heel, varus and adduction is simultaneously corrected. And the last, once we correct the whole deformity, finally we should not do a plastering for equinus. It will happen, it will correct by further correction. But at the end of all correction deformity, we do a tenotomy and equinus should be corrected. So how we will correct? So this is a very, very interesting how most of the time 2 things occur here. Why first the cavus, why it is cavus is there? So cavus is because of it is a first metatarsal drop. The first metatarsal head is a plantar flexion. That's a cavus deformity. So in the manipulation of the cavus correction, first we have to lift the cavus. The principle is if you lift the cavus at that time, whole metatarsal head in a come in a single line. Like suppose it's a plane of sole, whole from first to fifth. Then the main thing it's a supination. 4 foot goes in a supination. So this is a correction of this is the first cavus correction. Now the second cast, what we will do? Again, there is a very important thing. We have to identify the talar head. So where is the talar head? First, we have to identify the fibula. So this is a fibular landmark, and go 1 centimeter anterior and inferior. You will find the talar head. So now we have to use the fulcrum. This is a put our thumb over that, and this is a fulcrum, and you have to abduct the foot. Now, important thing is here. We have to abduct the supinated foot, not in a pronation foot. When we pronate the foot, so this is a right maneuver. We have to abduct the foot by using fulcrum. It's a supinated foot. So when you apply the second cast, it looks like that. So all toes are in a single plane. It's a plane of the sole. So you have to abduct the supinated foot. Once you go further casting, like in a second cast, third cast, and fourth cast, what happens? Up to the fourth part, it will become neutral, but it should not be pronated. That's very important thing. And the last, when you apply the cast and you will make a knot, it will be very easy to remove the plaster. So, where the most of the time, what is the wrong manipulation? Even I also suffered so many times. And when I learn exact maneuver, that is a very good retrospection on me. So what we did generally, so this is a wrong maneuver. So what we are doing abduction. But the thing you see that we are doing abduction in a pronated foot. So what happens exactly? Once we pronate the foot, the cavus indirectly or cavus will increase. Cavus will increase and all subtalar kinematics, it will not move properly. Your whole subtalar joint will lock. And that it leads, sometimes it's difficult to correct heel varus and foot become resistant. So very, very important maneuver. This one we have to identify. We have to abduct the foot within a foot in a supination position. And finally, we all know that once we foot get corrected and foot become 50 to 60 degree external rotation, there is no cavus, there is no adductors, heel varus is corrected, then most of the time, in my experience, 90% of the time we require tenotomy. So we are going detail. Next speaker will go explain about tenotomy. So I conclude my talk. So as early as possible, treatment should be started. and thorough understanding of Ponseti method that will really help to manage Clubfoot very carefully. Thank you. Thank you, Ganjwala sir.
Thank you, Kamlesh, for excellent presentation and explaining the basics of Ponseti technique in detail. Now we move on to the third topic, and that topic is really important because we have successfully corrected the clubfoot. However, according to the everyone's experience, we have seen that the recurrence rate is pretty high, and the literature says that 20 to 40% is a relapse or a recurrence rate. So, how to correct the relapse, how to identify that, it's very important. And for that, I invite next speaker, Dr. Atul Bhaskar from Mumbai, to speak on the subject. And this is very interesting and very important for all of us. So over to you, Atul.
Thank you, sir.
Just again a comment here. Atul has a wonderful paper which is published on early relapses and recurrences, which I recommend everybody should read. It's a brilliant paper, and I am sure he'll quote from that.
Thank you. I'll just share my screen. Yeah. Okay. So my topic for today is Clubfoot relapses, and as Dr. Dhiren has pointed out, it's an increasingly problem with more and more people doing the Ponseti. And already Govardhan has alluded to the fact that you can diagnose Clubfoot very early, and Dr. Shinde has shown cases coming like this. So in India, we get a whole spectrum of cases, right, coming from antenatal period to this very, very severe deformity. So whether early diagnosis makes a difference, it really doesn't matter. I think the treatment is important, as if you can start them very early. Now, we all know that following the Ponseti casting, the principle of casting is the brace which usually determines the relapse. And if you don't put a brace, the relapse is as high as about 70%. And with good compliance, it can come down to less than 10%. But more or less across the world, the range varies from 20% to 60%. So this maintenance phase becomes much more critical than the actual treatment phase. Now, how do you define relapse? Now, this is from the exam point of view and also for practical point of view. This relapse definition is basically based on the fact that any recurrent deformity occurring after the commencement of the foot abduction orthosis that required further treatment. That means their foot has to be corrected by Ponseti principle and the correct splint given. Then only this definition is valid. And this has been well documented in as early as 2010. Another paper looked at the type of relapses which present, and it gets a bit confusing. So we got early persistent relapses. It begins shortly after the initial correction and continues till age 4. And this is a common type which we see in practice because of poor brace compliance. Then you have the late onset relapses which begin after 4 years. So the biology kicks in once the brace stops and there is some muscle imbalance. The worsening relapses are ones which begin before age 4 but are progressive. And there are unknown onset relapses. So these are again very common in our country where children take half treatment or full treatment, then they're lost to follow-up and present within 4 years. So this paper from Mackey is really worth reading to look at the type of relapses seen in practice. The assessment of relapses gets a bit confusing because every surgeon has used his own definition for relapse. So if a child requires minor surgery like a tendon lengthening, it's called a minor relapse, and if the child needs a full-blown release, then it's a major relapse. So we really have no classification for relapses. And we know that brace designs influence the relapses in a big way. And the other thing which I would like to really highlight is even today, this is in the beginning of this year, how we document Clubfoot is very important. Now, this child had come to me, with this kind of documentation, splint given, no mention what was the Pirani score, what was the foot size, what was the morphology, evert imbalance. So I think this has to change, and I think this is where POSI and IOA can, maybe form a common white paper on Clubfoot and how it is bread and butter for general research and how we document Clubfoot so that we can think of preventing relapses. And it's been shown that in low-income countries, the relapse rate is very high, and it is basically based on the poor brace compliance. And Dr. Ponseti himself has mentioned that relapses can occur because of the excessive collagen synthesis and retraction that can persist until age 4. So the biology is again not in our favor. So that's why the maintenance phase becomes very, very important. And we had a relapse rate which we published in 2006, almost 16%, and despite doing almost 90% cases with tenotomy. So again, the maintenance phase becomes important. So why do we need to classify these relapses? I think it's important to have a common classification, a common language to gauge the relapses. We know that all deformities don't relapse at the same time once you start the orthosis. The relapses are usually flexible initially, and that's the time you should catch them before they become rigid. But there are some early signs, and I think this is very important to identify when you see the children in a follow-up clinic. So you must look at the muscle imbalance, the peroneal power, whether they walk with the great toe inflection, or there is adduction during walking, the poor fanning of the toes on stimulation of the sole, forefoot supination on weight bearing. And this is very important, critical, that when they lose the ability to dorsiflex, that means they're getting loss of the dorsiflexion leading to gradual equinus. And this is an important sign to detect early relapses. And we know that the deformity which recurs first is the one which corrects last. So equinus is the one which we correct last, but tends to recur first. And we also know that the relapses are flexible. So hence, if you identify them very early, we can start recasting and try and get the foot back into a normal position. This is what I mean about persistent flexion of the toe. So when you stimulate the sole, this toe looks bent, and there is poor everter power, poor fanning of the toes. So these are early signs. Then if you look at the morphology also, look at the creases, look at the short great toe, the calf size, the foot size, all these tells us that the collagen is very rigid in these cases. And when you start casting them, when you get edema in the first or second plasters, there is a problem with lymphatics as well. So these are the ones which are going to be really challenging feats. And I think Maulin will discuss the atypical feat. So what we looked at is our classification was looking at the flexibility of the clubfoot. So we started with the mild type, which is there is loss of dorsiflexion from 15 degrees to neutral, dynamic adduction, which are flexible deformities. Then we go to the rigid ones where there is deformity in one plane. So typically you get an equinus contracture where you could not get passive correction to neutral, a fixed adduction contracture, and then when there were two or more deformities. So we actually had made this into 3A and B, but then we had to then combine this so that it doesn't get very confusing. So early relapse pattern is classically seen when you see the children in follow-up, when there is poor brace compliance or they're using a non-standard brace, you'll find that they will get these loss of dorsiflexion. So with the bilateral clubfoot, you document the range, passive range in the clinic and then see how it is decreasing. As long as they can maintain above 20 degrees, that's a good sign, and you can compare with the opposite side. So these are the ones I would really cast them again. If you get these, you identify them early. Despite parental reluctance to cast, I would really tell them that this is one I would cast, or you can increase the bracing time to 14 to 18 hours, and then we can review the child back. Some of them may end up needing a re-tenotomy. This is again a challenging surgery. It is not easy. Believe me, I've seen a lot of scars placed at wrong positions. So one has to take in consideration the previous scar. There is massive scarring sometimes in the deep area. So when you do a re-tenotomy, you may not get that dorsiflexion. So I would not hesitate to open it and do a Z lengthening. Very rarely I would do a capsule release in children who are less than 2 years. So if you get an early loss of dorsiflexion, you can, if they are unable to squat, you start casting or you do a re-tenotomy so that you can get back into this alignment, and this child is at 4-year follow-up and he is able to squat well. So you had a mild recurrence to begin with, which you treated with casting and re-tenotomy. This pattern is the most commonest which you see in practice is the dynamic supination or adduction, where the heel stays neutral and the deformity is completely passively correctable. And these are the ones, you can examine them, you'll find that the dorsiflexion is good, but when they walk, they invert, and this is because of the muscle imbalance which they tend to have. And also I've seen them, if you look at the brace critically, you'll find that the brace angle is hardly about 10 to 15 degrees. So first try and improve the bracing angle, try and get the foot into more abduction, and try and correct it by using more splinting. Some of these which persist despite your splinting, despite your compliance with dressing, then those are the ones I would go ahead and do abductor hallucis tenotomy. And in some cases, if they're 3+ or more, I would also do a tib and transfer, a complete tib and transfer. So these are really cases where they have dynamic supination, and we have a video on that. So this is how I would do. I do a percutaneous abductor hallucis tenotomy, and then we correct the forefoot supination, and then re-brace them. These children, they stand like this typically. So we have to cut this tendon. I'm not saying this is the only cause, but it helps to decrease the adduction. Sometimes one can do when you do re-tenotomy, you can actually do what is called a forceps-assisted tenotomy when you can't identify the tendon clearly because of the previous scarring. You can insert a small mosquito, cut the tendon completely, and then get a good plantigrade and dorsiflex foot. When you get rigid patterns like these, you start thinking of surgeries, because these ones, again, you can cast them. But, again, parents are not very keen sometimes on casting, so you can try a couple of plasters. If they don't budge, you can then go ahead and do a surgery. My only worry with multiple plasters is you can actually cause flattening of the talar dome. And if you see the children in long term with multiple casts, they always have a flattened dome and they have some stiffness of the muscles of the joint. So I really don't hesitate them to operate. If after 2 or 3 plasters they are not yielding to normal dorsiflexion, I would do a posterior release, do a Z lengthening, and then again followed by a couple of plasters and get the dorsiflexion and squatting back. So I know that they will maintain the correction. This is what we do. If it's not a very tight foot, I would just do a hemi-Cincinnati, release the tenda achilis and also the scarring. And you'll be surprised that the scar goes right under the capsule. And sometimes you have to even open the capsule so that you get at least 20 degrees of dorsiflexion on table before you cast them. Then you got deformities in 2 planes, that is either equinus or cavus or equinus or adduction, which are fixed deformities. These ones will need surgery. Again, you can start plaster. You can give 4 or 5 plasters if the parents are willing. So again, counseling becomes very, very important. What road you are trying to take, whether you want to treat them with multiple plasters, or if they're not able to follow your compliance, then I would rather go ahead and do a surgery. So these are the ones I would, when the parents come like this with a foot deformity, you can see from the footwear how the leg position is. These are the ones you really want to take into consideration about casting them again. So if they don't respond to casting, I don't hesitate to do again a surgery. So these are transpiriform osteotomies, lateral closing wedge, which all of us are familiar. At the same time, we do a tib and transfer and get the foot into a plantigrade shape. So I'm not a big fan of multiple plasters because many of the patients have already had plasters done and they're coming for a second or third opinion. And so I really would just give 1 or 2 plasters, test the skin, and then go ahead with surgery. So these are the ones we see in practice, and I think this is what Dr. Shinde also shows. Many of these feet which come untreated come like these. So you should define relapses and untreated feet differently. And we also look at the brace pattern, brace compliance. So anybody who wore the brace less than 8 hours had a high chance of getting a grade 3 relapse. So that's why it's critical that the brace should be worn at least 8 to 12 hours. More than 12 hours is best. But our parents' compliance decreases after age 2.5. So this is where the bracing timing stands. Recently, we acquired a gait lab, so now we are studying children with Clubfeet, looking at their transverse plane deformities, and this hopefully we'll be able to answer some more questions about relapses caused by bony deformities. So in conclusion, I would like to end my talk, but there are a number of factors which can cause relapses, both extrinsic and intrinsic, some of which may not be under our control. If the feet are resistant, you may try to use a different protocol, which Maulin discussed. Try and classify your feet. Try and use the same standard pattern, whichever classification you follow, so that you have an idea that these feet are getting worse. And that is very important to document. And late surgeries, I think Dr. Negandhi is going to cover. So I try and leave my talk here. Thank you very much. Thanks.
Thanks, Atul. That was very concise. And I will just ask you one question here. What do you think is the commonest cause for a relapse being left undertreated? I would not say treated, not treated, undertreated. we have always blamed the parent of the patient for not complying to braceware. But do you believe that some of it is our fault also, that we are loath to accept a relapse as sort of a failure of our primary treatment, and we tend to continue pushing them, nahi dekhte hain, dekhte hain, dekhte hain, and they really get worse with time. We don't identify the early grade 1 relapse and take action immediately for the fear of looking foolish. Do you think that is true?
I think, Sandeep, it is partly true, partly it is the biology also not in our favor. So if a child, as we see these children, if a child has got good evocative power and they're able to squat, I think these are two critical signs. If they're able to maintain that in every follow-up, so I see them every 4 to 6 months, I don't think you will find that kind of relapses. The ones you are talking about are the ones where there is, parents may say they're putting the brace for 12 hours, and then you see the mother and the father arguing, 8 ghanta pinate ho, tum 6 ghanta pinate ho. So those are the ones where I think the biology is not working, but we're trying to push the brace for a longer time. And like you said, we try and be as conservative as possible, because, when the child grows up at 2 and 3, the child tell the mother, I need to put one more plaster above the knee. And they'll take a second opinion.
Yeah. They run away and they feel it's your failure.
Correct. So, as you get senior, I'm sure you're getting these patients coming from other orthopedic surgeons. You are in a position to actually, cast them because somebody else has told them casting. They refuse and they come back to you. So I think it's a game which is 50% both sides. I won't.
Yes. I think we should also take responsibility for some of the relapses. That's what I wanted to point out.
I agree.
And also, I think with IOA, we should have some funding for a project with POSI to develop a brace which can be monolateral. That bar is the killer. If we can get rid of that bar somehow, more people will be compliant. So what I have been doing is, when I remove the last plaster, I am using Ortho, that thermoplastic.
Correct.
So when we do the casting the third time after tenotomy, I first put a Ortho and get a corrected mold, and then ask them to put Velcro on that, and then give the cast. And when the cast comes off, put them in Ortho, which is separate for both legs. It works like a cast. So rather than that bar, they will be more compliant. It's just a thought. Maybe all of us should explore this.
I think, with Dr. Dhiren here, with Dr. Shiv Shankar here, I think this is the need of the hour, because we are seeing almost 40% relapses. And at a general orthopedic level, I think this is where IOA and POSI can make a huge difference, because it's a common problem.
Because what has happened is with Ponseti, the correction is very rapid and we are very happy. But following up and maintaining them becomes a bigger challenge for longer period.
Absolutely.
Yeah. Dhiren bhai, any final comments before we ask Maulin to talk of atypical Clubfeet?
Oh, yeah, you are absolutely right that now the major challenge which we are facing is the relapse and the recurrence. Correcting the primary Clubfoot or idiopathic Clubfoot is not a problem, but relapse is still is difficult, and every patient coming to us in a follow-up, and particularly those in a borderline, it's really difficult to tell them that now you need to go for the plaster treatment or something else. So you are rightly pointed out that. So now with that we go to the next topic, and that is about the atypical Clubfoot. And why it is important, let me tell you what my professor suggested me when I started my practice. He said, Dhiren, it's very important to know what you can do, but it is equally important to understand what is beyond your capacity. And atypical Clubfoot is one thing which is really difficult to correct and manage. So why this lecture is important at this meeting? Because it's very important for those who are novice to the Ponseti treatment or for a Clubfoot management, that this is one area, if you embark upon the treatment in these cases, then failure rate is very high. And before you decide to treat atypical Clubfoot, please understand the problems and the challenges. So with that, I request Dr. Maulin to share his views about this atypical Clubfoot or a non-idiopathic Clubfoot. Over to you, Maulin.
Thank you, sir. I hope you can see my screen and you can hear me well. Okay. So non-idiopathic Clubfeet, and the question is, does the technique change? So there are studies, and Ponseti himself noticed that about 6.5 to 10% of total Clubfeet cohort has some atypical etiology or non-idiopathic one. So when you treat 10 idiopathic Clubfeet, one of them would have some either syndromic affection or some atypical symptoms, and so you have to check on your technique. The typical casting technique, end point of treatment, post-treatment protocols and results are different for idiopathic and non-idiopathic Clubfeet, which one should take in consideration. So there are 4 types of Clubfeet which should be included in non-idiopathic ones. The first and foremost is the atypical or complex Clubfeet, which I will tell you in a moment how it is different from the idiopathic one. We also see a good share of post-arthropedic multiplex congenital Clubfeet. And then comes the Clubfeet which are associated with spina bifida or myelomeningocele. And finally, there is a battery of syndromes which have Clubfoot as an association. So we'll discuss them one by one. The atypical or complex Clubfeet, Dr. Ponseti started his technique of treating idiopathic Clubfeet way back in 1950s. But in late 90s, they found that some of the Clubfeet, they behave abnormally, although they look pretty similar to idiopathic ones. But when we start treatment, they may go bad. And this Clubfeet were termed as complex or atypical Clubfeet. And this paper came in existence in 2006. So this is the patient who looks like a bilateral severe Clubfeet, and Dr. Ponseti himself started casting on this baby. And after 3 casts, 2 casts slipped off, and that never happened with Dr. Ponseti himself. And what he found that this child had hyperextended great toe, the deep posterior crease, and the plantar crease was present not only on the medial side but also on the lateral side. And due to plaster slippage, there was a lot of edema and skin abrasions. So these are the signs which were not seen on idiopathic feet, and he considered, or he termed it as atypical or complex Clubfeet, where the main element of deformity is hindfoot as well as forefoot equinus. And in his series, when he saw a young orthopedic surgeon should be able to identify this. This is not a typical Clubfoot, this is a atypical Clubfoot. So if you see the tendo Achilles, or one should have a habit of palpating the tendo Achilles. In typical Clubfoot, the tendo Achilles is tight and fibrotic only in the lower half. Takes 3 or 4 plasters to gradually achieve external rotation of 60 degrees. But in complex Clubfoot, it is very easy to correct the external rotation. And so if you keep on doing further plasters till the end point of 60 degree, some of this patient would develop midfoot break and valgus deformity of the forefoot. And as this patients also short and fibrotic quadriceps plantae, these patients have forefoot equinus as one of the important elements. So if you see the sole of these children, on the typical Clubfeet, you will see the medial crease, the plantar crease only on the medial side, while on the atypical, you will see the plantar crease running across the sole completely. And this is very important and most conspicuous finding. So try to watch the sole completely and you will be able to diagnose it. Because of the tight quadriceps plantae, the sole shape would look very abnormal, and that should arouse the suspicion that this is not a normal Clubfoot, this is an atypical one. Now, this is a case where there was bilateral Clubfoot. The left side was typical and right side was complex. And because of the tenting and forefoot equinus, the foot apparently looks pretty smaller. So the abnormality in the foot size or the sole size can also raise the suspicion so that this child is having the complex foot on the other side. In typical clubfoot, the lateral border is pretty straight, but in atypical, you will find the tenting on the lateral border due to plantar flexion of third, fourth, and fifth metatarsals. In typical clubfeet, plantar flexion or pronation is only due to first and second metatarsal. Here, all the metatarsals are going down. And if you see the tendo-Achilles fibrosis or tendinous part, it's in lower half, and you can see here there is flattening of the calf till the proximal 2/3. And because of this intrauterine fibrosis, the tibia has plastic deformation. So the tibia, which is straight in typical clubfoot, will found a peg-shaped or a cylinder shape. And this is the reason why the plaster applied in 90-degree knee flexion has a tendency to slip off. And so the technique modification is required here. The dorsal skin will be puffy, as you can see in the atypical situation, and the toe will be hyperextended, as you can see. This puffy skin is there. So main element, as I mentioned, is hindfoot and midfoot equinus with a prominent plantar crease passing all across the sole is the pathognomonic sign of atypical clubfoot. This is the hyperextended toe. There should also arise a suspicion, which is a tenodasing effect on the extensor hallucis longus. And the moment you correct the forefoot equinus, you will see that this toe will get straighter. Do not do the tenotomy of extensor hallucis longus in such cases. It is not that that muscle is tight. It is the plantar flexion of the metatarsals which are producing this appearance. If you keep on doing casting without identifying this deformity and you keep on doing 40, 50, 60 degree external rotation, we have seen that some patients would develop abduction deformity and midfoot break. So you can see the X-ray here where the metatarsals are going out from the mid-tarsal bone. So we should identify this early, and the end point of external rotation is only 20 to 30 degrees and not 60 degrees. In first couple of casts, to correct the pronation of the forefoot, the supination degrees are pretty high. We need to give the cast in 70 degree of pronation of supination in few cases where there is severe pronation, and that is one of the modification. The end point of external rotation is not 60 degree as we see in typical club feet. The 20 degrees of external rotation is sufficient. Otherwise, it will invite the abduction deformity of the foot. To correct the forefoot and hindfoot equinus simultaneously, Dr. Ponseti mentioned what's known as two-thumb technique. So with the help of two-thumb, you dorsiflex the forefoot. The thumb should be at the base of first metatarsal and the fourth or fifth metatarsal. Your index finger should be on the dorsum of foot holding the talar head, and your middle finger should be lying behind the heel. And with that, you try to bring the heel down. At the same time, you are forcing the forefoot in dorsiflexion. So this is termed as two-thumb technique, where you dorsiflex the metatarsals and bring the heel down simultaneously. In typical club feet, we use one-thumb technique. Here, you use two-thumb technique. I saw Dr. Ponseti using his index finger to mold the heel and then try to bring down while the plaster was setting. And he termed it as a heel pulling down maneuver. So this one should try to do. You need to stretch out the tendo-Achilles. What other important thing he taught or he explained is many patients, when we do the dorsiflexion of metatarsals, will show blanching phenomenon. Now, we also see this blanching phenomenon in typical club feet, and that is a temporary spasm of vessels. But some patients with atypical club foot have absent dorsalis pedis artery, and so in those cases, the blanching would not resolve, as we see in idiopathic Clubfeet. And if the blanching does not resolve, you need to take the plaster off, because they have only plantar vessels and that get stretched out because of the dorsiflexion of the metatarsals. So while you apply plaster for atypical Clubfeet, keep the toes open so that you can readily look for the circulation in the toes. And if it doesn't return back after some time, you take the below knee plaster off and put the foot in a little bit of plantar flexion. The knee flexion in atypical Clubfeet is about 110 degrees, suggested by Ponseti to prevent slippage of cast. In typical Clubfeet, we prefer 90-degree casting, but one needs to put a little bit of more flexion to prevent the slippage. Tenotomy protocols are same. Once you get about 90 degree of neutral dorsiflexion, then you may add tenotomy to bring it up. The end point of dorsiflexion is not 15 or 20 degrees as we see in typical Clubfeet. If you achieve about 7 to 10 degrees of dorsiflexion, then it is fine for atypical Clubfoot. And occasionally we may need plantar fascia release also, percutaneous, in these patients when it is very tight. In splint protocols, the external rotation, which we put at 60 degrees in typical Clubfoot, here we have to put only in 20 degrees in order to prevent forefoot abduction deformity. This is a case, bilateral Clubfeet. There were 7 plasters slipped off. It was treated at other place, and because of this severe equinus, this thing slips off. And this is how patient presented. You can see the hyperextension of the great toe and severe cavus bilaterally. And this was the surgical profile and plantar side, how it looked like atypical Clubfoot. And this is after the application of modified Ponseti technique. And this is about a year's follow-up. You can see the puffiness takes a little time to resolve, and dorsiflexion is about 10 degrees, and that is adequate. What I've seen over years that these patients gradually they convert into a normal looking feet, and by the age of 2-3 years, their feet looks pretty good and the dorsal puffiness resolves. This is 1 year follow-up of the same child. You would see that plantar crease would gradually disappear. Another case, similar, 7 plasters applied elsewhere, plasters slipped off, skin abrasions, and there was toe dorsiflexion, deep sole crease completely going through the plantar surface, treated with the modified Ponseti technique, and it got corrected well. This is a year's follow-up. So, average number of plasters are definitely more than the typical Clubfeet. In some patients, it required up to 10 plasters, and dorsal puffy skin takes time to get resolved. Retenotomy was required in a few patients where there was rigid equinus, and relapses can happen and can be treated with recasting. Posterior release was required in one of the patients which remained persistently in equinus even after tenotomy. As I mentioned, plaster slip-off, plaster breakage, and skin abrasions are the main issues if we fail to identify that this is not a typical Clubfoot. Now, Clubfoot in arthropedic multiplex congenita needs a bit attention. There are many papers recently.
Sorry to interrupt, like we are running late, so can you...
So I'll summarize in a moment.
Yeah.
So arthropedics, we have to use same technique, but they need more number of plasters, and there are higher rates of relapse. And in MMCN syndromes, the technique is the same. We have this paper from Vadia recently, and they have good result at 5 years. But there are higher relapse because of the underlying neurologic condition. To all the readers, all young surgeons, this is a nice systemic review, which is summary of non-idiopathic Clubfeet, which involved 1,100 patients. And in all non-idiopathic Clubfeet, number of plasters are more. The need of tenotomy is more over 90%, and there is very high recurrence rate of 43%. And success rate is little lower, now it's 65% compared to 95% in idiopathic ones. So in atypical Clubfoot needs little modification of plaster technique. In rest of other non-idiopathic technique is same with the outcome differences. Thank you very much.
Yes, now I request next speaker, Dr. Rajeev, to speak on the very important topic of what is new in surgery. No doubt surgery has been becoming less and less common in Clubfoot, but still we need to go for surgery in some of the cases. So I request Dr. Rajeev to share his views on this important point.
Good afternoon, sir. Am I visible and audible?
Yes.
Yeah. So, of course, the surgeries are still integral part of the treatment of Clubfoot. So, in my talk, I will include what are the common surgical procedures and what has been the change in last 10 years. So, as we all know, surgery remains the integral part of clubfoot correction in walking age and relapse clubfoot. There are various number of soft tissue surgeries like open tendo-Achilles release, medial release, tibialis anterior tendon transfer, and joint distractors with external fixators, and so on. So also there are so many bony surgeries like calcaneum osteotomy, triple orthodesis, with or without Elizaro, supramalleolar osteotomies. So all these surgeries have some of the complications. So it is, as we have already discussed over the last 1 hour, that it is better that we treat all these clubfoot with the Ponseti method of treatment. But some of these kids who require surgery, they have a lot of complications as they grow ahead. So we have to really use a la carte approach and see what is the best for a particular individual child. So first we have to assess whether this deformity is dynamic or it's a static deformity. If it's a static deformity, we can always try, if it is a dynamic deformity, we can always try to do a serial casting, and if required, we can do a tibialis anterior tendon transfer. The technique will be shown subsequently. So this is an example of a child who was treated with tibialis anterior transfer on both sides, and he is doing quite well. If the child is older and has persistent equinus, then you have to correct the equinus by doing a posterior release. Only soft tissue will be sufficient, and joint release may not be required if you get good correction after doing subsequent lengthenings. But if the joints are involved, then you have to release the subtalar joint through the posterior, medial, and lateral side. And this is an example of such patient who was treated with a radical posteromedial as well as a posterolateral release. You can do this with a Cincinnati approach or a conventional posteromedial turquoise incision. So this is an example which was treated with a 6-year-old child and with 2 years of follow-up. Another child with a constriction band who had relapsed of his clubfoot and was treated with posterior release, and this is his follow-up video. So if the deformity is still persistent after age of 4 years and the deformity is at the forefoot level, then you may want to do a talonavicular capsulotomy on the medial side, abductor hallucis release, tibialis posterior lengthening on the medial side, as well as add a lateral blaze closing wedge osteotomy of the cuboid on the lateral side, so that you can make the foot well corrected. This is an example of a child whom we had treated with on one side with osteotomy and other side with a tendon transfer. And this is her follow-up. So if the deformity is at the forefoot as well as at the hindfoot level, you may have to do all the procedures which I mentioned previously, along with a calcaneum osteotomy. It could be a lateral displaced calcaneum osteotomy, as shown in this slide. The patient, who is an adolescent boy, having a heel varus and was treated with a sliding osteotomy of the calcaneum and was fixed with two screws. If the deformity is still persistent and the child is an adolescent one, then you can do a triple orthodesis, or you can go for a midfoot osteotomy as well as a calcaneum osteotomy together. You may combine this with an external fixator or without it. This is a child who had a severe clubfoot deformity at adolescent age. He was operated multiple times, and we did midfoot osteotomy and along with the posterior release and corrected this. We have published this in Indian Journal of Orthopedics for the reference. Another way of treatment of a severe neglected clubfoot is a triple orthodesis. This is a salvage procedure, and this should be the last resort if the things are not doing well, or there is a lot of excessive scarring and stiffness of the foot. So now I'll come to the things what have changed in last 10 years. So we asked the question, is it possible to apply Ponseti method in walking age clubfoot? Is it possible to correct the relapse clubfoot with Ponseti method? And we'll discuss some of the newer methods of deformity correction. So of course, there is a literature now that you can correct the walking age clubfoot with Ponseti method of treatment. As shown in this paper from Wadia Children's Hospital, they have treated children up to the age of 10 years with Ponseti method. According to this paper, 1/3 of the clubfoot relapsed and needed further treatment. Despite a high rate of treatment, a supple, plantigrade and pain-free foot is achievable without the need of extensive soft tissue surgeries or bony procedures. So these are the examples of cases which were treated with Ponseti method in a walking age group. Another paper by Agrawal et al. Has also shown that you can successfully treat clubfoot by Ponseti method in a walking age group. Another paper which quotes about treatment of Ponseti method after 1 year of age. This is a paper from Iran, which they had treated with 13 serial cast and a posterior release to achieve a painless plantigrade foot. So there is a systemic review of Ponseti method in children with clubfoot after walking age, and conclusion of this paper says application of the Ponseti method in children with untreated idiopathic clubfoot older than walking age leads to satisfactory outcome, has low cost, and avoids surgical procedures likely to cause complications. So the next question we asked is it possible to treat recurrent clubfoot with Ponseti technique after the child has been operated? So this paper shows that you can still do it, and they have manipulated the clubfoot again, and this paper quotes around 86% good result after Ponseti treatment in a operated clubfoot. Another example where this child was treated with 8 serial cast and lateral column shortening procedure to achieve a good planeless plantigrade clubfoot. So what are the newer methods? If there is a equinus at the ankle joint, you may try to do a hemiepiphysiodesis over the anterior aspect of the distal tibial epiphyseal plate, and gradually the deformity will get corrected. If the child is adolescent child and has got good talus, then you can go for supramalleolar osteotomy to correct the residual ankle equinus. So to conclude, with introduction of Ponseti method in walking age children, rate of surgery has definitely been gone down. Severity of surgery is also decreased. surgeries have become more target oriented, and extra-articular surgeries are more preferred than soft tissue surgeries. Thank you very much.
Thanks, Rajeev, for briefly covering what's changed. As we can all see that because of Ponseti, even older children are now being treated by Ponseti, relapses are being treated by Ponseti, and the trend is to do more close treatment, either by Ponseti or by fixators, rather than open bony surgery, which causes extensive scarring. So the world has changed, and the supple relapses, as Atul has shown, are managed by tendon transfers and limited surgeries. So gone are the days where we did extensive posteromedial plus lateral releases, and we are focusing more on closed biological response of tissue to fixators and plasters. So thanks for bringing that out. The next we'll have Kirti talking about this biological method, fixators in Clubfoot, and follow it up with a video. We'll do the cases in the last. Kirti, over to you.
Yeah. Thank you, Sandeep sir, and good afternoon, everyone. So with the advent of Ponseti technique, now surgeries have significantly reduced, but still fixators, they do find a role, especially in our clinical scenario where untreated clubfoot or late presenters are still a significant concern. So the obvious indications for fixators, they become a late presenter or a untreated clubfoot, syndromic clubfeet, clubfeet after soft tissue release, which has become very rigid or resistant to treatment or to soft tissue correction or casting, recurrent clubfeet, and it can also be used as a part of staged correction. So you can apply a fixator to achieve part corrections, stretch the soft tissues so that the amount of wedge required for osteotomies decreases in cases of very severe clubfeet. Single stage correction in these presentations, they have their own issues in the form of wound complications, vascular compromise, as these are acute corrections. Since this is a multi-dimensional and a multi-apical deformity of foot, so taking out a wedge and planning precisely is difficult. So it lands up into inadequate corrections. And another thing is it can lead to foot shortening in an already shortened foot because of the disease. Joint stiffness, it occurs with the single stage correction, but this is again common for the fixator also, because fixator, it puts the joint into a congruous position, the joint surfaces which are non-congruent. So over a period of time, even with fixators, joint stiffness is very common. So why do we want fixators? They allow simultaneous correction. These are minimal incision surgery, so there are reduced risk of cutaneous and neurovascular complications because of gradual correction, and it prevents shortening of foot and basically can achieve a multi-dimensional deformity correction. But everything is not rosy with fixators. So these are technically demanding, especially if we are talking of a ring fixator, that is Elizaro. JES is relatively easier and a shorter learning curve to learn. A follow-up is very, very essential. So you have to choose your patient. You cannot have a patient who doesn't come for follow-up and is not motivated. So choosing a patient for fixator is again very important. And there are some complications with fixators also, which I'll be touching upon in the subsequent talk. So whenever you're applying a fixators, you can apply it with a soft tissue release, or you can apply it with a osteotomy. So the soft tissue release, it works on the principle of distraction histiogenesis. That is, the soft tissue distraction, it eliminates the existing contractures and puts the joint into a congruous position, achieving a plantigrade foot. While in case of osteotomies, it is the distraction osteogenesis. That is, the regenerate develops from the osteotomy, putting the foot in a plantigrade position. Soft tissue release, there is a very controversy in the literature about the timing of the release, but it surely does minimizes the damage to the tarsus and the metatarsus. It decreases the load on the system, and especially the post-operative stretching and the pain, it reduces significantly. So you can achieve the correction in a shorter period of time once you combine soft tissue release with the fixator, and it lands the patient into lower incidence of complications. So what all do we need? You can go for an open posterior release. You can go a percutaneous TA tenotomy. You can go for a Hoek's lengthening, a plantar fascia tenotomy, and sometimes in case of severe inversion deformities, you can go for a posterior tibial tenotomy. And then you apply a fixator and distract the deformity. So soft tissue distraction, the two common fixators which we use are JES and Elizaro. because of the familiarity of most of the surgeons with JES, I'll focus more on it. So how do you construct it? You make a tibial hold with 2 or 3 wires depending upon the age of the child and the size of the leg. You connect 2 L rods to create a Z, and then you put an anti-toggle wire in the tibia anteriorly on the shin of the tibia, and then connect the assembly. Similarly, you create a calcaneal and forefoot holes. Important for forefoot hold is that you pass the wires medially as well as laterally, and while passing, you have to keep the toes flexed, and you have to make sure that all the 4 wires, the medial as well as the lateral wires, they try and engage all the metatarsal bones. Similarly, you create a construct on the calcaneal side by passing 2 parallel wires. You can use the distractors itself as a zig to pass these wires, and then you pass an axial wire to complete the assembly. You connect this assembly finally with the calcaneo-metatarsal distractors and tibio-calcaneal distractors. There is an anterior rod which connects the forefoot to the tibial ring, and this is mainly the final assembly, how you construct a JES assembly. When we see Ilizaro, it's more or less in principle same as JES except for the placement of the hinges. So this is the tibial module, this is the forefoot module, and this is the calcaneal module. Now above is the distractor for the supination correction. This is a distractor for correction of adduction. Here you place the equinus hinges. Equinus hinges have to be placed in the line of the axis of the ankle, and below is the equinus distractor. So more or less the principles remain the same, except that in Ilizaro you get the advantage of using hinges and getting more precise correction in the axis of the deformity. Post-operatively, you start differential distraction. So you distract more on the medial side, and whatever you distract on the medial side, you distract half on the lateral side. As this is essentially a soft tissue correction, you can start on the 2nd or the 3rd post-op day. You can start with 1 millimeter, but then can increase according to the pain tolerance of the patient. The regular pin track care and the fixator care, which we are all aware about, has to be taken in account. Once you achieve the correction, so the common protocol is if you have taken 4 to 6 weeks to achieve the correction, you put the frame into maintenance for the same amount. After removal of frame, you give a cast for around 4 weeks, and then you brace the child depending upon the severity of deformity. You can brace him up to 6 months to a year. There are some complications which are associated with fixators. The regular I am not going to talk about, like the pin tract infection and wound complication. The specific for a clubfoot deformity is the cartilage compression or the epiphysiolysis of distal tibia, which is seen. Especially when you are using a JES fixator, it is advisable to initially distract the joint by 5 to 6 millimeters so that you have enough space in the joint, and then you start the correction so that the cartilage, they don't crush against each other and cause joint stiffness. Another very important complication is anterior subluxation of talus. So what we need to consider here is that whether we are using JES or we are using Ilizaro, these all are unconstrained fixators, which means because the clubfoot is a multi-apical and a multi-dimensional deformity, there is not a single pora which we are dealing with. So you cannot place the hinges exactly in the axis of deformity, which then leads to translation of the talus while you are correcting the equinus. So this translation you have to prevent. So there are 2 ways you can prevent it. One, you pass a pin through the talus and then connect it to the tibial hold, or you can put, in case of Ilizaro, you can tilt your calcaneal frame a little bit posteriorly so that once you're distracting, it tries to push the talus posteriorly and not anteriorly. A word on osteotomies. So osteotomies basically are reserved for older children who have very stiff joints, especially a stiff subtalar joint, non-congruent, and in case of neuromuscular feet where you want basically a bony correction so that it lasts longer. Very common, there are multiple osteotomies which have been described, but very common is the V osteotomy, in which the posterior limb, it passes posterior to the subtalar joint, and the anterior limb, it passes through the sinus tarsi and the neck of the talus, and they both coincide on the plantar surface. By this V osteotomy, which is a talocalcaneal, you can basically correct any deformity of the foot. This is a very versatile osteotomy. This osteotomy, you have to start distracting on the 3rd day because these are cancellous bone, and one of the complications or one of the main problems is premature consolidation. So you start distraction on the 3rd day. So I'll just conclude my talk with a case. This was a 10-year-old child. He was a late presenter, untreated club feet. and we applied elizarofame with percutaneous soft tissue releases, and this was his 6 months follow-up. So take home fixators, there's a very versatile technique. They can cause very good multiplanar deformity corrections, but they have their own problems. They have a learning curve. You have to choose your patient wisely, and you have to tackle the complications. Thank you.
Yes, Kirti, now you can go for your videos, because videos are more important for general orthopedic surgeon to understand like how to do a percutaneous tenotomy.
Sure, sir. Yeah. So I'll be showing you how to do a tendo-Achilles tenotomy. So first, what marks the end of our plaster sessions is a midfoot Pirani score of 0, which basically means the coverage of the talar head by navicular. You achieve a forefoot abduction of 60 degrees. There should be no medial crease, a straight lateral border, and anterior end of calcaneum is mobile under talus. After this, once you examine the child and you have achieved more than 20 degrees of dorsiflexion, you don't need a tenotomy. But if you haven't achieved the end goal, then you go for a tenotomy. As there are multiple ways to skin a cat, a tenotomy can also be performed in different ways. You can perform the tenotomy in a supine or a prone position. You can perform it with or without anesthesia. You can section the tendo-Achilles with a 15 number blade, a 11 number blade, or a 18 gauge needle. Till you achieve the desired result without causing complications, the choice of the procedure depends upon the surgeon's comfort. So I'll be just demonstrating how I do it. So basically, we take the child under in supine position under caudal block anesthesia. I like to do it under anesthesia. First, once you have taken the child, you examine the correction. That is, the Pirani midfoot score is 0, and you have your child. The foot is ready for tenotomy. What I'm demonstrating here is that rest of the things is corrected, but the child still has equinus. So I can take the foot to neutral to 5 degrees plantar flexion. So now you palpate the heel cord, palpate the heel. You have to, the site of the tenotomy is 0.5 to 1 centimeter above the heel cord to prevent damage to the cartilage. Then you introduce the knife parallel to the tendo-Achilles and anterior to the tendo-Achilles. You turn the knife 90 degrees. You turn the knife 90 degrees, and with a synchronized, after you have done the tenotomy, you apply a pressure dressing for 5 minutes. And once the bleeding stops, you apply the cast in 20 degrees of dorsiflexion and 60 degree abduction for 3 weeks. Important here is that once you are applying the cast, you have to ask your assistant to hold the foot into dorsiflexion before applying the cast bandage. Because if you do dorsiflexion after applying cast bandage, it can lead to anterior sores. Also, in cases of atypical club feet, or in cases where I have not achieved the desired dorsiflexion of 20 degrees, what I do is I call the child at 10 days and change the cast in OPD and further stretch the posterior structures, the posterior capsule. Although this is a very simple, straightforward procedure, but there have been complications which have been reported in which the peroneal artery and the lesser saphenous vein have gone damaged. There is another report in a case where there was a single artery leg and the posterior tibial was damaged and the child landed up in complications. So you have to learn the technique, and once you learn it, this is a fairly straightforward technique, but you have to be aware of the complications. Thank you.
Thank you, Kirti, for enlightening us about the very important part of the Ponseti technique. So without spending much time, now I request Dr. Atul to share his videos about the anterior tibial tendon transfer. Yes. Kirti, can you stop sharing your screen?
Yeah, I'm trying to, so just wait. Give me a minute. I can't unshare.
Once Atul shares, automatically this will go away. Atul, you can start sharing your screen.
Okay. I can't share because it's showing.
Yeah, just wait, sir. I'm just trying. I can't get the zoom on my screen. That's what.
Ashok, can you unshare him? Yeah, okay.
Thank you.
I'm just going to briefly talk about the tib and transfer. The ideal indications are that the foot should be flexible. They should have dynamic supination in stance and swing with big peroné. If they're not, you can try serial castings and increase your splinting duration. And if you don't succeed, you can go ahead with the tib and transfer. But typically, I would do a 3-incision transfer. So you do a middle incision near the base of the first ray. How is the tendon? Take care of the saphenous vein. Do a complete tendon transfer. So incise the tendon from the base. Take a whip stitch, or if a child is older, you can use an anchor. Take the anterior distal incision to retrieve the tendon from here, and then a lateral incision for the anchor point on the third cuneiform, where you make a drill hole, and you can use a whip stitch either PDS and then anchor it to the foot, the sole of the foot with a felt or a gauze in correct neutral position with neutral dorsiflexion and over eversion. So I'll just show the video also. This is the example of the 3-incision technique, and this is the result. So the incisions are very, very small. The video essentially is a 2-incision technique, which is Maulin's video. So I'll just share that. So I'll stop sharing this and I'll just share the other video. This is the 2-incision technique where your incision goes slightly more proximal near the ankle joint, where we are able to harvest the tendon right from the sheath itself. So with blunt dissection, you try and harvest the tib and tendon. You can pass an artery and feel the tautness of the tendon.
Atul, we can't see it.
Oh, you can't see? Sorry.
We are not shared the screen.
Share the screen.
1 second, 1 second.
Video is not seen.
Let me share it. 1 second. Can you see it now?
Yes.
You see?
Yes. Now we can see.
Okay, so this is a 2-incision technique where the incision is made along the ankle joint. So you can harvest the tib and tendon very close to the sheath. And with blunt dissection, you can feel the tendon, the taut tendon. It is a very thick tendon, which is has got no muscle attachment at this level. Right up to here, up to the midfoot, mid-leg, there is no muscle attachment to tib band. So it's a very strong, sturdy tendon. And here, this is a slide by Dr. Maulin, who's patiently dissecting the tendon. And then you can take a whip stitch using either you can use non-absorbable material, ethibond, or you can use a PDS, which you prefer. And make a strong stitch here, because this is one which is going to anchor your tendon to the bone. So you can see the gliding of the tendon. Make sure you've got enough length and excursion. And this is the lateral incision over the third cuneiform. Again, it's very important to identify the peroneus tertius tendon and retract it medially, what is shown here. And then you see some fibers of the extensor digitorum communis, which you can then bluntly dissect off the fascia. There's a nerve on the lateral side. One has to be very careful. So once you open this fascia, you can do a blunt dissection and identify the third cuneiform. So with the blunt dissection with the artery forceps, you can see you identify the periosteum of the third cuneiform. And one must localize the mark under IITV so that you don't make the incision too lateral. So it's worth bringing the machine inside, localizing with the needle before you make your drill hole. Once you confirm the position, you can use a drill to make a drill hole and then widen the drill hole with the artery.
Govardhan, can you mute yourself?
You widen with the artery because the hole then becomes smooth. It doesn't cause any tendon fraying, and you can go right up to the base, feel the base artery on the plantar surface. Once you made a reasonable size tunnel for the tendon, then you can glide your tendon inside. So you can use 2 Keith needles. This is the confirmation of the hole. And then you transfer the tendon. Now, in this case, the tendon is still below the retiniculum. So the advantage is you don't get much bowstringing, and you get a nice lever for the tendon to dorsiflex the foot. So this is the passage of the tendon subcutaneously, and here you get the tendon. You can see you have changed the track of this. Now this is not an easy technique for beginners. So sometimes you can do a 3-incision technique and harvest the tendon proximally. And these are the 2 Keith needles. Always keep the needles with you. Don't use these curved needles. We have seen needles being broken inside. So you must have straight needles so that your line of pull is good. And try and put the needles about 30 degrees to the vertical. If you make it too oblique, you may damage the medial plantar nerve or the lateral plantar nerve, and you can see the needles coming out at the base. Make sure you don't pierce the assistant. Once the needles are out, you can retrieve them from the plantar side along with the threads. And you can see how you have to do this gently so that you don't damage the needle or the threads. And I've seen problems where the needle can break. And this is the cork you can use to prevent any skin maceration over a gauze. And as the needle is pulled, the threads will come out. And you can see both the threads are pulled out here. And the assistant will then give the tension. You see the tendon gliding inside the cuneiform, and that's very important. You must identify a good tendon to bone contact. Once that is done, the assistant can then can tie the knot at the base. The foot must be kept in neutral dorsiflexion and slide over correction. This is very important, so that the pull of the tendon is right where you want it to improve the eversion as well as the dorsiflexion. And once you do the plantar stitch, you can then come back and take some periosteal sutures here, so that the tendon is well covered and you got a nice tendon to bone contact. And this is a very important step. So there is no laxity here. You have someone holding the foot, someone holding the threads, and then you're tying this tendon. So this is an important part of anchoring the tendon. So in older child, I would use an anchor, but the bone has to be really good quality. You can use 2.5 anchors by Smith and Nephew and do the same technique without making this hole. And here you tighten the lower part again. Make sure you don't break these threads, because once you break them, you will lose contact. So somebody has to hold them, and then you tighten them. Once you confirm they're tight, you can then leave the foot and see the foot position. Typically, the foot will be in neutral and in slight eversion. You can see that. And then you do the usual casting, above knee cast with the foot in slight eversion and about 15-degree dorsiflexion. And I'll just show this. I'll just stop sharing this. And then typically with these surgeries, you can get a reasonable correction. You can get a good result. You can see this is a tib and scar is well healed. You can see the dorsiflexion. And even in the gait pattern, you see the gait of these children are pretty good. And so as they walk, often I would combine this procedure with either a cuboid osteotomy if it's an older child, or sometimes you can do a posterior release if required. So it can be done in combination with other surgeries, because the cast duration is going to be about 6 weeks. So it doesn't matter whether you're combining this or you're doing separately. And that's the kind of thing you get post-correction. So you can get nice dorsiflexion of the foot and also the... Yeah. Thank you very much. Thanks.
Thanks, Atul. So I think the take home from this video has to be, one, the foot has to be supple. You can't do a tendon transfer with a stiff foot which is deformed. Everybody who's going to do this, please remember the foot should be supple and corrected, and there has to be dynamic supination. Second, do it after 3 to 4 years when there is ossification of the third cuneiform. Don't do it when it is cartilaginous. So it's to be done a little later rather than too early. And how you do it, 2 incision, 3 incision is your choice depending on your training. As long as it's under good tension, that should work very well. It's one of the commonest done operations today, more common than doing a soft tissue release. So we'll come to the third video by Kamlesh on a very important thing. We see that after casting, there are a lot of patients who get sores and scars and plaster cutting tool injuries. So I wanted him to show how to remove a plaster and how to apply the brace, which is very important for maintaining correction. Kamlesh. Kamlesh, unmute yourself.
Yeah. So most of the time we are using plaster of Paris. So that's why we will, before the cast must be stopped the day before we coming to the clinic, or for the second plaster. So the same procedure we can perform at the clinic. So we are using plaster of Paris and not using fiber cast right now. I'm not using fiber cast. So what we do at the clinic, so put the child in a tub or sink, and let them warm water should get into the plaster. It should be properly wetted. So the things are very important here. So while ending your plaster end, this mark will be very useful during the removal. So what we see, once it get it wet properly, then it's very easy to identify the landmark. So this is the plaster end. So what we do, there's unroll the plaster because when getting it is soft, that will be easy. Once we'll remove the plaster, so there may be some chance of skin sore and the skin will damage. So most of the time we remove the plaster at the clinic while using. It should be properly wetted. Child should be properly rested. It's very important thing during remove. We have to prevent some sore. And the second thing is foot abduction brace. We all know that to prevent relapse after removal, foot abduction brace must be worn. So there are different varieties of foot abduction braces available. So, but the principle is the both foot should be high-toed, attached to the end of adjustable aluminum bar. The distance should be between the heel of the shoes. It is equal to the baby's shoulder. And whenever the shoes of the clubfoot is outward rotated 60 to 70 degrees. So whenever there is a unilateral clubfoot, the normal foot should be in external rotation up to 30 to 40 degrees. And the ideal Ponseti protocol is brace should be worn 23 hours a day for at least 3 months, and then after at a night and during nap time. So most of the time mother will learn, but some basics thing we will take care for that. So always use a cotton socks. So after first plaster we remove the plaster, the skin become very, very sensitive. So always use cotton socks. The distal end should be cut so we can see the toes properly. Second thing is very important. If you are using this kind of brace, the ankle strap is very important. When you put foot into the brace, the ankle strap should be firstly worn. And by the time, secondly, you just use a second strap. And be sure while applying this type of braces, be sure that all toes of the baby should be straight out. So it should not be bent. Sometimes we'll miss it and leads some shoe bites. And finally, once you over the brace, then look for the heel. So this is very important step. Sometimes it gets loose and heel is off and it leads a recurrence. So after wearing, or we have to teach mother that the heel should be touched. So these are the basic things for a foot abduction brace applications. Yes. Thank you.
Thank you, Kamlesh. So it's important that you don't allow your mama to remove the plaster using a plaster cutter in your busy OPD, because I have had situations where the parents were extremely unhappy after such a beautiful correction because somebody cut the baby's toe and created an abrasion or a sore. So all the people who are watching this all over India, I'm sure clubfoot is something everybody is going to treat. So when you remove the plaster, it is very important to be very gentle and soft when you remove it. And Kamlesh has shown us how. And soaking it is the best way. In my practice, ask the parents, I teach them once, we give them a video on WhatsApp and tell them to follow the instructions, make them remove at home. Traditionally, all our parents want to do oil massage and bath. So you tell them in the evening or early morning, you do whatever you want to do, oil massage, bath, and you should not have an interval of more than 6 to 8 hours between the next cast and removal of plaster. So then come back for the next cast. I have always found if you involve the family, they are more connected to the treatment. So I don't remove it myself. I teach them and they remove the plaster at home. Okay, with that, I will hand over to Dhiren Bhai to conduct the cases.
Yes, now invite the first case presenter, Dr. Samir Desai. So he will be showing interesting points, the practical points about the clubfoot management.
Yes, sir. So through my case, we'll like to revise some of the principles that we have learned today. So this is a typical preterm child with a CDK with CTV. So this is a non-idiopathic clubfoot. This child had located hips. The upper limbs were normal and birth weight was only 1.5. kg. So we should remember over here that we should not start treatment immediately. I usually wait till the child is approximately 2 kgs or some fat has appeared, so that and the complications during plaster treatment are less. We should wait till the birth weight of the child is minimum 2 kg. So this child was counseled for Ponseti method, and the order for correction usually in this is correct it, and we were trying to correct both the things simultaneously. So in this case, we were able to achieve flexion of the right knee to about 90 degree, but left knee we were not able to flex. The midfoot score was 0. And in this case, hence we decided to correct the equinus with a percutaneous adductor, percutaneous TA tenotomy, and for the knee we decided to do quadriceps plasty. So the plaster was repeated for a month, and since this was a non-idiopathic clubfoot, the child may recur. And you can see over here that after surgery we got good knee flexion, but at 6 months you can see that the TA has become tight again. The parents were counseled for repeat Ponseti method, but they did not come back, and then they came back after 2 years, after approximately 1.5 years, when the child was 2 years old. And this was the position of the child. Knee flexion was still good, but you can see that all the deformities in this child had recurred. Again, we counseled them for Ponseti method. So we have already seen that Ponseti method works well even in older children. Of course, in non-idiopathic clubfoot, you will have limitations, but idiopathic clubfoot, they do quite well. And you should try serial Ponseti method even in an older child. So they were counseled for Ponseti method, and you can still some equinus was there, some heel varus was there, some amount of adduction we were not able to correct. So in this child, we decided to do a limited surgery, means only posterior and small medial incision, and we had a good result in this child. So remember, for non-idiopathic clubfoot, you must tell them that there is a chance of recurrence. You can try repeat Ponseti method even after recurrence. But the advantage of this was that the scarring is less, and the amount of incision, the amount of structures that you have to release are also less after Ponseti method, after repeat Ponseti method. Thank you.
Yeah, thank you, Sandeep, Samir, for very excellent demonstration of the difficulties of this combination of CDK and the clubfoot and the problems which we face during the treatment. So very well conveyed the message. So now I request Dr. Tanvi Shinde to present her case about clubfoot.
Thank you, sir. I would like to thank POSI and IOA for this opportunity. So this was a case of a 5-year-old boy who presented to us with an untreated CTV. This was his gait. You can see that the severity of the clubfoot he had, as he is already walking on the foot. So what were the management options? This patient presented to us around 10 years back, and he was around hundreds of kilometers away from us. So surgical release were associated with wound complications, stiff foot, and overcorrection, while the choice of JES fixator was associated with poor compliance, pin tract infection, and skin necrosis. As these patients traveled from far, we were skeptical about the compliance, and they belonged to a poor socioeconomic strata. Their parents were illiterate. So to avoid this complication, we thought to combine these two procedures. And we did a single incision posteromedial release, applied JES fixator in an undercorrected position. Remaining deformity was corrected using JES. After 1.5 months, JES was removed and then cast was given for 1 month, and patient was allowed weight bearing with it. After the cast removal, corrective orthosis was given. So we treated one leg with this JES and combined surgical release, and the other leg was corrected using only JES fixator. And this was the result. As you can see, the right foot is corrected nicely, but in left side, the metatarsal adduction is still there. But we found that the combined method was equally effective in treating the severe deformities for untreated CTV. Then we studied around 31 children with 51 clubfoot deformities in the age group of 2 to 5 years who had neglected, recurrent, relapsed, or resistant CTV in severe or very severe grade. We operated them using modified turquoise one-stage posterior medial release along with JES fixator. We could achieve the deformity completely in about 43 cases, and partially correction was achieved in 8 cases. The average range of motion was fair in most of them, while 2 cases had focal necrosis. So at the end, for these patients, we found that single stage posterior medial release with JES can achieve a goal of functional, painless plantigrade foot with minimal skin or wound complications. And this can offer an excellent opportunity to the patient for maximum surgical benefits, especially where compliance is compromised. Thank you.
Yeah, thank you, Dr. Tanvi. Excellent case, and like you have shown a very good correction. I must appreciate that this is very useful technique, particularly for like the patients coming from remote area and presenting late. So I just would like to summarize the whole session before I hand over to Dr. Sivasankar, that at present the gold standard for the clubfoot management is Ponseti technique. The initial results are really good for the idiopathic clubfoot. However, the biggest challenge is the relapse, and we see relapse in around 20 to 40% of the cases. And we also need to understand that relapse should be treated very early and aggressively. Idiopathic clubfoot is easy to treat compared to a non-idiopathic or a syndromic clubfoot, and we need to modify our strategy for the correction. And Dr. Maulin very well explained us what are the differences in the management of non-idiopathic clubfoot. JES correction and the surgical treatment definitely have a role. It's not like they are not indicated at this stage. For us and for the relapse and for the late presenting cases, they are very important. And we show our various tips and the techniques for the management of these patients. So with this short summary, now I hand over to Professor Sivasankar for his last comment, and then we can end the session. Over to you, Dr. Sivasankar.
Thank you very much, Dr. Hiren Ganjwala sir and Dr. Sandeep Patwardhan for excellently coordinating and convening this CTV session. I must thank the IOA subcommittee of pediatrics, Dr. Ajit Shinde, chairman, and the people along with him, Dr. Tanappan and Dr. Kamlesh Devmurari. I must thank all the faculty who have shared lots of tips and tricks, including how to remove a plaster, how to make the patient comfortable. So many tips and tricks have been shared. I thank all the faculty, Dr. Maulin Shah, Dr. Kirti, Ramnani, Dr. Tanvi Shinde, Dr. Kamlesh Devmurari, Dr. Atul Bhaskar, Dr. Govardhan, Samir Desai, Rajeev Negandhi, last but not the least, Ortho TV, our own people, Dr. Ashok Shah, for having this coordinated this technical aspect. I'll hand over to the chairman, Dr. Ajit Shinde. Thank you very much.
Thank you, sir, for your presence and concluding this webinar. I thanks all the faculties and participants because of which this wonderful discussion has occurred, and I am sure most of the orthopedic surgeons are benefited with this knowledge. Thank you, everyone. Thank you much.
Thank you. Dr. Shinde?
Yes. Ashok, you can stop live streaming.
No, you can, just a minute. You can just announce the next will be septic arthritis and sequelae.
Yeah.
Yes. Next topic is septic arthritis.
Okay. Last Sunday of next month.
Yeah, July last Sunday.
Okay. Thank you very much.
We are planning to include South. If South people are not interested, then we will think of East. But we have decided the West, South, East, North, and Central zone, and lastly again all zones.
We have a very good, enthusiastic, and very dedicated pediatric people in South. So don't worry about that, sir.
Okay, sir. If you are assuring, then because
stop recording.
I talked with one of our members, he
Recording
told that there is nobody